All right. Well, the questions that got sent through, so seeing as Catherine, you're on the centre here, there was a question that we had online, and then invite people who are here to come up to the microphone. The Vax Cora was a question of whether it's ETEC. So can you give a context, background, and why that question was asked?
Is this working? Yes. Great. Excellent. So ETEC, which is a common cause of travellers' diarrhoea, has been associated with one of the other vaccines, but for Vaxchora, it does not have an approved indication for prevention of ETEC.
Right, so maybe not quite as broad spectrum as the current
it's still
cholera vaccine.
Yeah.
And travellers' diarrhoea, there's a debate about what causes it. E. coli, is that the...
So E. coli is one of the main causes.
Oh, but it could be.
That's right.
So the new one maybe isn't that broad. It doesn't have... another question we've got online to you, Paul, about the flu vaccine, and talked about should everyone who we consider high risk have 2 in a season?
Hi, thanks. And this is something that's debated often. At this stage, as far as I'm aware, there's no evidence for giving 2 except if it's in kids for the first time, or potentially after a bone marrow transplant or something extenuating like that. So routinely, we don't recommend 2. Some other exceptions to that can be pregnancy, for example, because we do recommend that in each and every pregnancy. And so sometimes if they received it seasonally and it's a while away, and sometimes if people are traveling and it's been a while since their flu vaccine, if they can get one, they might have a second one. But as I say, at the moment, it's not routinely recommended, but it is something that's talked about often.
Okay, thank you. We mention of a new vaccine that was listed on the NIP vaccine list, and in addition to the Infanrix Hexa, and there was a question about interchangeability. I think the comment was that they're not interchangeable. Yeah, it's worth the microphone. Yeah, thank you.
No, it's not recommended. It's recommended that whatever you start with, you continue. In the event that the vaccine is not available, you can refer to the handbook where it says in those circumstances you can change over, but no, absolutely start with one and finish the 246 that way.
Okay, so we've got a question about going on for the National Immunisation Program. Where does MenB fit? Where is flu on the National Immunisation Program? And a slightly separate but different question, why are the states giving different advice for their vaccines? People nodding their head about that. I think I know the reason. It's not a good reason, but anyone like to comment about where does MenB fit? What's flu on the National Immunisation Program? And why do states make it complicated?
You want me to?
Yeah, start.
So that one, states often have separate programs depending on outbreaks in their communities. So, for instance, the Tasmanian one in 2018 was because we had significant outbreaks. I know South Australia were doing research, so that might be part towards those, but it is often based on what states have got for funding and what they see as a need in their community. It is a pity that we have states and a country as well, and that it wasn't all countrywide, but that's the way it is. Now, there was a question about MenB there too.
Well, my understanding, I think Queensland's added it to, South Australia's got it. Some other states are talking about it, but someone also talked to us about a new vaccine coming out. Was it? What do people recommend for MenB?
Yeah.
Meningococcal B.
Yeah, so meningococcal B is recommended in the handbook for all infants from 2 months of age, for that infant area and at teenagers. As we sometimes describe it, it's when people put things in their mouths. Babies put lots of things in their mouths. Teenagers also share body fluids. So I think that's the 2 high-risk groups. So that's where it is recommended for, chiefly for those, but unfortunately not funded across the board, but funded in special circumstances. And obviously it sounds great that there's potentially a vaccine that's got all of them in there, and that might make life a little easier, and maybe that might be picked up by the NIP.
So, Catherine, do you want to comment when you think the all strain might be out there? But the question about what's recommended but not funded is an ethical issue for any provider to what we actually say to our patients. And I think, Leanne, you were saying that it's important to remind people you've got to inform people that there's a vaccine. You may not actually be able to fund it, but they need to know they're out there. So, Catherine, when do you think it's going to be here? Did you get a sense?
So the pentavalent meningococcal vaccine that's been submitted to the TGA was submitted, if I remember correctly, in May, June of this year. So generally it's a 12-month turnaround. Initially, I'm sure it will come out as a private vaccine.
I'll go to a slightly political question about why can't nurses just have the autonomy to give vaccines? Why do they need to have it? Anyone like to encroach on the politicalness of that? Or so the Immunisation Coalition supports vaccines given properly and have taken a view that it's important to do vaccines properly, make sure they're recorded properly, and that they're incorporated into the notes. After that, I think, Leanne, any comment?
I think that people who have done that separate nurse immunisers course to become authorised immunisers have gone through several other steps. Practice nurses, yes, probably are familiar with all those steps, but they need to have the benefit of having a GP in the building. The reality is they actually do a lot of it independently, but as I said, they have a GP literally by their side in that same building and can't vaccinate without them in the building. I think that's probably how most practices would work. And it is also a Medicare issue. If you are going to, the patient does have to have had some passing scene with the doctor.
Gary, there's a question about COVID, and it was pregnancy and COVID vaccine. And then the other part of the question was, does long COVID increase someone's vulnerability to an early death or speed up the diseases? Like we know, flu causes heart attacks. Is COVID doing that? And is it long COVID sort of premature deaths?
I think with regard to pregnancy, there's plenty of evidence there to say that the vaccine is safe. And the advice is that pregnant women should get the vaccine. And there's been no issues. Been a couple of studies done on that, and I think the data is really, really good. And the child is also obviously protected for a short while at least. With regard to long COVID and chronic disease, I'm not sure there's any evidence that says it will exacerbate chronic disease in the same way that flu does, but you get the feeling it might. But there isn't any evidence out there saying that it's going to lead to increased problems with say heart issues or stroke or anything else we might associate with influenza.
Thank you, Sarah. Online, did you want to comment on the new malaria vaccine and how good it's going to be, or how effective it might be? But is it still a major advance?
Yeah, look, I think the malaria vaccine is a major advance for endemic settings where malaria exists, but it's not something that we're likely to be using in travellers. There are a lot of reasons for that, but I won't go into them. I think, similarly with some other vaccines that are coming out, such as dengue vaccines, where there's good evidence in endemic settings that they're reducing the risk of severe disease. I think there's still some complexities around using those vaccines in travellers. So not at this stage.
Okay, Gary, you mentioned something about watching out for side effects of the COVID vaccines. Any comment on that and when it shifts from being not recommended to recommended, and your thoughts on the COVID vaccines and the side effects from them?
Well, as we know, all vaccines have side effects. The ones that were the most serious for the COVID vaccines were initially, particularly in the under 30 males, where we saw higher levels of normal of myocarditis and pericarditis. As the numbers have come in around the world and the reports have come in, that appears to be for the under 30s, in my view anyway, of the data, and people will argue about this, to be about 1 in 30 to 40,000. But in people outside those age groups, probably 1 in 100,000 or more. So the risk is very, very low of getting myocarditis. Now, But there are less severe issues. People get irregular heartbeats and so on. People also seem to get GI problems. Some people talk about brain fog, things like that after a vaccine. So there are other issues that are not very well collected. And the best people, I think, that have collected this on mRNA vaccines were FDA. They occasionally publish a snapshot. In lectures I've given before, I've shown this snapshot of 42,000 people that have received mRNA vaccine, and something like 17% of them have issues with irregular heartbeats. 25% of them have GI issues, for example. So these are transient and tend to stop after a few weeks, but nevertheless, I think we still need to collect good data on that. And people generally don't report those kinds of symptoms because they're not that serious and they are transient. And we just have to be aware of those transient issues. They will resolve, and it's very, very, very rare that they lead into something more substantial. But in terms of long COVID, there's plenty of data out there now showing that 1 in 10 people have some aspect of long COVID. It might be 2 or 3 months. It might be 6 months. Some people have it for a year, but it does appear to resolve by itself. And as I mentioned in the talk, there's a few papers out now that have shown there are some biomarkers that we can now use for diagnosis, because diagnosing long COVID is so difficult, if not impossible, given other issues that people might have.
Thank you. So we'll come to talk about shingles vaccines in a second and a transition. But to Paul, why such low coverages for other groups than elderly? Any thoughts on why we've ended up with such? And then Sarah, a question around Japanese encephalitis vaccines and travelling in Australia. So Paul?
Yeah, great question, and one that I don't think there's a simple answer for. I mean, discussion around vaccines has become increasingly complicated post-COVID. I mean, there's still a lot of focus on COVID, a lot of misinformation, for example. I think a lack of awareness of the significance, particularly in those younger groups. So yeah, there's a host of reasons, and I think it's well worth investigating. And we're fortunate in our country we have some great groups looking into this. And I think we all need to try and address it as well. So I think letting people know what the risks are, that, particularly in children, they're a high risk group. They contribute to spread, as I mentioned. They end up in hospital. The death rate's low, but the risk is still high in that group. And so they're a high priority to get vaccinated. And we need to do a little bit more. I mean, for example, in my state, we saw big issues with that sort of 5 to 9 year age group. And so additional vaccine funding was provided. So it was provided free. And, initiatives like that seem to have a big increase in uptake. If we could maybe look at other things like that, maybe a bit earlier in the season, for example, that might help. So, yeah, not a simple answer, but one I think we should try and...
Thank you. And if we decide we want to fly overseas, but we don't like the airlines and we travel around Australia, should we all get a Japanese encephalitis vaccine, Sarah?
So I think, Japanese encephalitis, there's two things for Australians. One is whether there's endemic disease still circulating, and the other is thinking about disease in the region. So the Asia region is where most Japanese encephalitis cases are reported. As you're probably aware, we had 45 cases of locally acquired Japanese encephalitis between 2021 and 2022. The last of the locally acquired cases was reported in December of last year. So the focus of infection in Australia has mainly been in the Murray-Darling Basin. So there's been cases across South Australia, New South Wales and Victoria, but there's also been some cases reported from the north, particularly in Northern Territory. So I think, we know that Japanese encephalitis circulates between mainly birds, mosquitoes and other animals. So humans are a dead-end host, we're accidental hosts. It's mainly people who are kind of outdoors for long periods of time exposed to mosquitoes, so people working in those areas. I think, the recommendation is a month or more of travel in Asia, or if people are doing shorter trips, we think about cumulative exposure, so they're going to do multiple trips into an area. Are they doing activities that are going to put them at increased risk of exposure to mosquitoes, like hiking, camping and so on? And I think for those people, there's a good rationale for the vaccine. Imagev, the live attenuated vaccine, has good evidence to support that it provides immunity for at least 7 or 8 years. So for people who are doing multiple trips to Asia and or trips to their holiday home up around the Murray, I think there's a good rationale for having the vaccine. in a nutshell.
And at Melbourne, it's supposed to be 4 seasons in a day, but it turns out the whole state of Victoria, you have fires one day and floods the next. So the vaccines are available on private. So it's about mentioning to your patients that they're on the table. They just may not be funded because some of the states have got their own programs for funding, I think. Is that right, Sarah?
Yeah, that's right. So each state is funding its own program for people at risk. So that's mainly LGA based. So people who are in certain LGAs at risk may be eligible for the vaccine. People are also eligible for vaccines if they're from a particular risk group. So if they work at a piggery or an abattoir or something like that, but otherwise it's on a private script. Around about between $250 and $300 for the Imagev vaccine, around about $100 a dose for the Gespec vaccine, and the Gespec vaccine you need 2 doses. Plus a booster dose of 1 to 2 years. So they actually end up being fairly equivalent in pricing once you factor in the number of vaccine doses.
A reminder, anyone on the floor can go to the microphones here, but you've just talked about the cost of some vaccines, $200 or $300 for a shingles vaccine or the new Shingrix vaccine, going to be on the NIP. And we understand, and behind the scenes, we understand there's rumours of an announcement tomorrow, exactly what the conditions are. But just a question to the panel, the current advice, the transition advice and the future advice, what do people think they're going to be saying about the shingles vaccine, what's available and is it worth the money and what should they do? We know it's the 1st of November, but is it 70? Is it 70 only? Is it the 70 and above? Is it the 65? Who's the group at 65? What do you do for a transition? If someone's 69, you understand all that. It was announced by Mark Butler in May that it would start, but exactly what do you do? Who's an at-risk group? Is it prednisolone, someone on dexamethasone for their sinus infection? So all of that fine print and the transition, which I'm asking the panel, a comment about someone who's 69 and a bit, do they wait? If someone's had 1 dose and then they turn 70, or if they had their first dose at 70, do they get the 71? All of those details are up for grabs, and the transition and the crossover and how long since you've had shingles and how long between the doses. Any comments from the panel? We thought we'd throw it into the mix, but we certainly know that something is going to happen on the 1st of November.
And I also had a question I was asking of Rod at the morning tea break. What should we be doing with our 71 to 79-year-olds? Should we be calling them in the next 4 weeks to get them vaccinated if they're missing out on the Shingrix? So that was a question I had.
And the issue there is if we give them a Zostavax now because they're eligible for a catch-up, do we have to wait 12 months till they're then eligible for their shingles, their Shingrix? And if they're 71 when their 12 months is up, what do we do? So my question to the panel for some opinions, and we'll see whether the Health Minister's got it right tomorrow when he makes an announcement.
I might start just because I've been dealing with that in our practice, knowing that this was coming, and we have people who have turned 70, and I have a lady who will turn 71 on the 16th of November. She is almost on hot call for as soon as it happens, because does she have a Zostavax, which we could quite legitimately give her, or do we give her the benefit of a vaccine that we know is a new improved vaccine? Nothing wrong with Zostavax. It was a good vaccine when it came out. It's just we've got new and improved. We don't no longer, most of us don't do our washing in a twin tub. We do it in a front-loading automatic, possibly with a dryer included. But, this is the thing. And we know that I have seen a lot of people with Zosta who had a Zostavax 3 or 4 years ago, and it's now, wearing out. So I think this is this tricky thing. But what happens if that lady gets shingles next week, and I could have protected her because I know the Zostavax would have worked for that. I have people who are coming in who are 64. I've paid and had a Shingrix. If they do put it on at 65, because I'll be 65 next year, tough. I wanted to be protected now because I saw 3 people with shingles in the last fortnight, and they weren't all in the sort of eligible for vaccine age group, but needless to say, none of them were exactly delighted about their event. So I think that's, you've got to sort of think about what's in and weigh up the risks. And it's like the funded versus unfunded question. You've actually got to put it to them, well, do you pay now and have this? Do you have the other one? Do you wait, knowing that there is a risk? Someone came in, they'd opted at, I think they're 67, so they'd gone and had a shingles on Friday morning. So that's the Shingrix on Friday morning. So that's, as I said, the conversation you've got to have. Yes, we don't know what the government's going to announce, and we can only guess. And I say to people, the government hasn't got buckets and buckets of money, so they do have to prioritise.
Gary?
I think there are ethical issues here. We should be giving people the best vaccine available that's the most efficacious. This is ridiculous. I think the College of GPs and others, the Immunisation Coalition, need to get on the front foot.
Thank you. So, Crystal, what do you say to people? It's not on the nip, so bad luck?
I think it's all about just telling the patients what's available and giving them the choice. And the reality is that there are some fantastic vaccines out there, but the government actually just doesn't fund all of them. So giving them that choice, and that unfortunately leaves some patients, you know, without the possibility of getting vaccines because they are so expensive. But I think as a practice nurse, it's my job to let them know what's available, what I recommend as being the best one for that person at that time, and letting them know how they can get it. So whether it is available by government funding, time factor is an issue, of course. And I think it's best, especially at this point in time, with the relationships that we've built with people over very recent vaccinations over the COVID time. They do want to ask us, and we can put out there that, you know, yep, things are, there are cost factors, and the idea of waiting for the government to come through with an answer is something that we're also quite well versed with, especially in Melbourne. So I don't think that's anything.
Very well said.
So.
Thank you. So I'm going to ask Paul his comments on advice about vaccines are recommended and if it's not funded and something like that. And then again to Sarah about when you're travelling overseas and someone says, my goodness, that's $800 worth of vaccines. Do I have them all today? Do you recommend shingles as well? So Paul, your comment?
Basically, I agree with the rest of the panel. You know, I think we have to inform our patients that there's a vaccine that I think the evidence is mounting to suggest is superior. But there are issues with funding that's not necessarily always tied to the best vaccine, and that there's not an inexhaustible supply of money, and there's a time delay, etc. So just because it's not funded doesn't mean people shouldn't have it, and we just need to present to them that we think it perhaps is better. At the moment, there's a cost associated outside of those groups that are going to happen. I think we're all getting lots and lots of questions, and there needs to be more clarity more quickly. And I agree with the comment that maybe some groups should be on the front foot about providing some guidance here, because it's incredibly confusing. But I think at the moment we just need to provide advice to our patients about what we know, and hope that the funding may be catching.
Yeah, Australia's challenge to say what's recommended by the expert group and what's funded, and what's recommended is important, and what's available is a third step. So Sarah?
Yeah, I think in the travel medicine space, most of the time we're giving people vaccines that aren't funded. So it's a relatively easier conversation to have. Shingles, obviously, reactivation of a virus that you've already got in your body. So it's not a travel related illness per se, but we'd certainly tackle that along with other topics in a travel conversation if it's appropriate. I think it's all about patient priorities, and people have different opinions on what they want in terms of vaccines. And some people are willing to pay out of pocket if they see that there's a benefit in being protected. So I think I completely agree. We need to have the conversations with our patients, give them the options and let them choose.
Thank you very much. So we're nearing the end of our time. It's been really good. Any final comments from the panel here or the people online? So the panel here, any final comments?
I would just add that I think the travel consult is a really good opportunity to bring the traveller up to date with their routine vaccinations. So that's
so not to forget the routine ones. And as you mentioned, that measles is still a challenge internationally, and that's something, and it's the Rule 66 that born before you've had natural exposure. Afterwards, you probably only had one. So just check either immunity or two, or if in doubt, give them the second one. So thank you. Important reminder, routine ones. Paul or Sarah, any final comment? Paul, to start with, any final comment?
No, thanks very much for allowing me to be part of a great discussion. Thank you.
Yeah, it's tough up at Noosa, isn't it? And Sarah, Any
Thanks
final
for-
points?
Thanks for me too. I agree with Catherine. I think, the travel consultation is a really good opportunity to catch people up with vaccinations. And that's why I chose to present some routine vaccines in with the travel talk. So
Thank you very much. So thank you, and thanks to everyone sitting on the panel, both online and off, and to participation. Thank you very much.